Hey, welcome everyone. My name is Tom Chun. I'm one of the ISPCTN site PIs and a member of the Echo Discovery editorial board. It's my pleasure to moderate today's session. Just a few housekeeping things to start with. The format of this presentation is about a 35-minute talk. I'm pleased to introduce Nigel Paneth and Kelly Hirko, who are presenting today. That will be followed by approximately 20-25 minutes of questions. Of note, everyone is currently muted, so if you have a question that you'd like to pose, please enter it into the chat box on the WebEx. We'll be monitoring that, and if we have time and I'm able to call on you, I will call on you and we'll unmute you and you'll be able to ask the question directly yourself. There is CME credit available for this presentation. So without further ado, Kelly is an epidemiologist and community-based researcher focusing on the role of lifestyle and behavioral factors in health disparities. She recently completed the NCI Training Institute for Dissemination and Implementation Research in Cancer facilitated course and is interested in investigating the implementation of evidence-based interventions in tobacco cessation and physical activities to address rural cancer disparities. Kelly earned her MPH in epidemiology from Boston University and her PhD in epidemiology from the University of Michigan School of Public Health. She completed a postdoctoral fellowship in nutritional epidemiology from Harvard's T.H. Chan School of Public Health and is an assistant professor in the Department of Epidemiology and Biostatistics at Michigan State University. Also at Michigan State is Nigel Paneth. He's a pediatrician and perinatal and child health epidemiologist whose research addresses the causes and prevention of child neurodevelopmental handicap, and especially their relationship to events in pregnancy and the perinatal period. He has a special interest in epidemiology of cerebral palsy and the causes and consequences of brain injury in premature infants. He has a long-standing interest in assessing whether clinical interventions are not only efficacious, that is, whether they work in clinical trials, but also effective, that is, that they can be and are being implemented in the real world and whether they are making a difference in public health. Without further ado, let me turn things over to Kelly.
Hi, thank you so much for the introduction and for the opportunity to speak today to the ECHO group on implementation science. More specifically, the title of my presentation will be Identifying Opportunities for Implementation Science Approaches in the ECHO program. And just to preface the presentation, I would like to acknowledge upfront that I'm not an implementation science expert, but as mentioned, I did recently complete the Training Institute sponsored by the NCI for Dissemination and Implementation Science. So today, my goal is overall just to provide a brief overview of implementation science approaches, but more importantly, to hopefully spark a discussion about potential opportunities for implementation science in the ECHO program. Next slide, please. So for today's presentation, I'm going to begin, as I mentioned, by providing a brief overview of implementation science, and this will include definitions for some of the key terms and also some suggested resources for further reading. And then next, I'll briefly discuss potential opportunities for implementation science within the ECHO program, including across the ECHO cohorts and the ISPCTN trial networks. And then I will turn over the presentation to my colleague, Dr. Nigel Paneth, who will present on specific implementation challenges in obstetric practice. Next slide. So what is implementation science? Dissemination and implementation research is collectively known as implementation science, and the overall goal of implementation science is really to move evidence into practice as effectively and as efficiently as possible. Dissemination research refers specifically to the study of targeted distribution of information and intervention materials to a specific public health or clinical practice audience. And the intent of dissemination research is to understand how to best spread and sustain knowledge and the associated evidence-based intervention. Implementation research is the study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings to improve patient outcomes and benefit population health. So a key term in implementation science is the evidence-based intervention, and this refers to a health-focused intervention, practice, program, or guideline with already demonstrated evidence of the ability of this intervention to change a health-related behavior outcome. So throughout the presentation, I'll be talking about evidence-based interventions or evidence-based practice interchangeably. Next slide, please. So why is implementation science necessary? As you can see in this figure on this slide, evidence-based interventions or evidence-based practices take on average 17 years to be incorporated into routine general practice, and only about half of evidence-based practices ever reach widespread clinical usage. This delay in translation could be attributed to several factors. For example, research-supported resources to study the effectiveness of an intervention rarely remains at study sites after the study is over. And moreover, a lot of these evidence-based interventions often have specific characteristics that make an unassisted translation into practice unlikely. So thus, it's becoming increasingly evident that the process of dissemination and implementation of these evidence-based interventions requires active strategies to ensure that this evidence is effectively understood, it's effectively adopted, implemented, and sustained in clinical practice. Next slide, please. So implementation science focuses on the how questions. It's about the process of getting these evidence-based practices into the clinical setting or the community. So for example, how do we get the evidence to drive practice? How do we get the evidence-based intervention to become standard care? How well does the evidence-based intervention fit with the study population? And how feasible is the evidence-based intervention in the given context or population setting? The goal of implementation science is to identify strategies that will promote the uptake of these evidence-based interventions that we've already shown to be effective into clinical practice. Next slide, please. So over the next several slides, I'm just going to touch briefly on the implementation science approach. And this includes the following steps: assess, prepare, implement, and evaluate. Next slide, please. So the first step involves identifying the evidence-based intervention or the evidence-based practice that you wish to implement, and then to engage stakeholders and partners to better understand the specific setting, the clinical setting or the practice setting, and the context of this setting. So this often includes a qualitative assessment of the setting's strengths and weaknesses, the overall culture, the feelings on change. And this formative evaluation will help to ensure that the evidence-based practice is relevant, and it will also increase the likelihood that this evidence-based practice will be adopted and sustained long-term. Next slide, please. The next step is to prepare for the implementation. And in this step, the researchers should consider how the stakeholder engagement will help achieve the goals of the evidence-based intervention. So here it's critical to try to maintain the fidelity of the intervention, which refers to the degree to which the intervention is implemented as intended, so that the specific health outcome or health behavior is changed. But in addition, it might also be necessary to adapt the evidence-based intervention based on the stakeholder input for a given setting. So for example, an evidence-based intervention to promote physical activity that is app-based may need to be adapted to address preferences of a target population, for example, a population that I work with often, which is an older rural population. So the challenge in implementation science is to try to maintain the effectiveness and the fidelity of the evidence-based intervention while also considering changing and adapting to the context in the population. So next slide, please. In the step of implementation, it's often recommended to use theories and models and frameworks to guide the implementation and inform the implementation. So I've listed here a few examples of some of the more commonly used models. This includes the CFIR model, which is the Consolidated Framework for Implementation Research, and the RE-AIM framework, which stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. And references for each of these models are listed here on the slide for anyone who wants to read further on these. Next slide, please. In the implementation phase, researchers need to identify the specific strategies or methods that they want to use to enhance the adoption of implementation and the sustainability of the evidence-based practice. And these strategies should be chosen based, again, on the context from the stakeholder feedback and also informed by theory and models. So in the table on this slide, I've shown several examples of how specific implementation strategies can be used to address the identified determinants from the stakeholder engagement. So for example, if there's a lack of knowledge in the community, then we can use potentially interactive educational sessions to try to increase the uptake of the evidence-based practice. Also, if there was a lack of motivation to promote the evidence-based practice, then we could try to put together some incentives or sanctions to promote the adoption of the evidence. In implementation science, we use the specific feedback from the stakeholders to guide these strategy selections, and we try not to make assumptions about what worked for one setting in terms of getting it to work in another setting. Next slide, please. So the next step in the phase is to evaluate the outcomes. And implementation outcomes are different than the clinical effectiveness study outcomes, which would focus on health effects or health behavior change. In implementation science, the outcomes center on the rates and the quality of use of the evidence-based practice. So in this table, I've listed several of the common implementation study outcomes, but I won't go through them all in detail now. Just want to mention that those are some of the common outcomes that you might see. And often in implementation science research, we use mixed qualitative and quantitative study designs that include multiple levels. So we look at the patients, the providers, the clinics, the health systems, and even sometimes the broader environment. Next slide, please. Okay, so here I have just provided some resources and papers if anyone is interested in learning more about implementation science approaches. I know I just went through a lot of information, but there's some really good articles that really try to describe implementation science for the non-implementation scientist. And so I've included some of these here if anyone's interested in finding out more. Next slide, please. So now that I've provided the overview of implementation science, I want to discuss a little bit about the relationship between epidemiology and implementation science. So as you can see in this figure, there's a bidirectional interplay between epidemiology and implementation science. Implementation science relies on the work of epidemiologists to inform the evidence base, to identify the gaps in health status, to contribute to the methods for design and measurement, and to inform program and policy evaluation. And as it was described in this paper cited on this slide here, the work of epidemiologists can be magnified by direct engagement in implementation science so that we can enhance the real-world relevance of epidemiologic research, and in doing so, increase the likelihood that scientific findings will be useful and will be consequential. Next slide, please. So with that in mind, I want to turn now to try to talk about identifying opportunities in the ECHO program. So for the ECHO cohorts, there are several ideas that come to mind that I can mention here, but really the goal of my presentation is to hopefully spur discussions across ECHO investigators for other potential opportunities to consider and incorporate implementation science approaches in our work. So by doing so, we can improve the population health impact of our work and reduce that time from our findings getting translated into practice. So one specific idea that came to mind is that we could use existing data from across the ECHO cohorts to identify gaps in practice and target populations for implementation. And another thought is that we could collect data across the ECHO cohorts to identify specific barriers and facilitators to the uptake of evidence-based interventions, and that can inform the adaptation of evidence-based interventions. I'm sure, like I said, there are many other opportunities within the ECHO cohort, so I'd invite the attendees of this presentation to consider this in your work going forward and think about how we can really try to have that broad population health impact by translating our findings into practice. And then also within the ECHO trial network, the ISPCTN, there are perhaps more obvious opportunities to conduct multi-site implementation studies to fill the gaps that we're identifying in the ECHO cohort work. Next slide, please. So I would like to just close with a question, posing a question to the group, and that is there enough interest to create a working group on implementation science in ECHO? So please consider this, and maybe we can discuss at the end of the presentation today. But now I'd like to turn the presentation over to my colleague, Dr. Nigel Paneth, and he will discuss specific implementation difficulties in obstetric practice.
Okay, next slide. Thank you. You have this. Can everyone hear me? Okay, I'll assume that's an answer. Thank you, Kelly, for giving an introduction to the concept of implementation science. And thank you, Tom, for your introduction, and Beth Harris for helping set this presentation up, which is coming to you both from Traverse City, where Kelly is, and 3 hours north of us, and here in the central part of Michigan from East Lansing. So I thought I'd take one illustration of practices, a pair of practices that are widely considered to be evidence-based, and yet we suspect are not fully used, and see if ECHO can help us understand the processes involved. And next slide, please. So before we can implement anything in a community, I'll talk about the things that you need to have. You need to have trials showing effectiveness, perhaps meta-analyses to show that the trials are consistent, and then finally, very often recommendations from professional groups that say this is what we should use. And I will give examples of 2 obstetrical interventions, and I will review for each one the 3 steps so that you can see we've gotten to the point where the evidence-based intervention is quite well accepted. And then I'll show some data that show that in spite of the above, we don't really have as full an uptake of these interventions as we might wish. Next slide, please. So the 2 therapies are both in preterm infants. The first is the use of steroids, dexamethasone or betamethasone in preterm labor to mature the fetal lung and improve newborn outcomes. This has been recommended in virtually all obstetric practice guidelines since the mid-1990s. And more recently, meta-analyses of at least 5 randomized trials show that magnesium sulfate administered in labor reduced the risk of cerebral palsy when administered in anticipated preterm labor before 32 weeks. Perhaps as a lot as the trials are for 32 weeks, you'll see the recommendations go a little further. Next slide, please. So steroids, the goal is to prevent lung disease and to prevent the neonatal mortality. Next slide. Next slide, please. Yeah. So the classic study is the 4th one listed here, Liggins in 1972, that got a lot of attention. Here's a summary of many trials that were done. As you can see, virtually all of them have odds ratios that are protective below 1. Several are significant. The pooled odds ratio is about 0.72, so we're talking about nearly a 30% reduction of perinatal mortality. This includes intrapartum stillbirths and early and neonatal deaths. The odds ratios for respiratory disease are a bit stronger, but I'm showing you just the findings for perinatal death rates. Next slide. And one of several meta-analyses that I could tell you about, this is the 2017. I think this is the most recent. And again, they support the continued use of a single course of antenatal steroids to accelerate fetal lung maturation in women at risk of preterm birth. What is meant by preterm birth varies a little across recommendations, as I'll talk about in a moment. Next slide, please. So the August 2017 recommendation from ACOG, their Committee on Antenatal Corticosteroids, they recommended a single course for pregnant women between 24 weeks and 34 weeks of gestation. They later say in the same recommendation, you might consider going up to 37 weeks, but the evidence base for that is much less conclusive. So most people are thinking that the target population should be preterm labor up to 34 weeks. Next slide, please. Now, the implementation of it is very uncertain. A recent study in looking at the use of steroids in low and middle income countries found in 29 countries the range of uptake was 52%. It was as low as 16% in some places. Now, we assume US use is higher, but there's not very much data. I was involved in a study in the early 90s, which was the very early days of use of these steroids, and we found in 4 hospitals in New Jersey that the range of usage of this went from 32% to 89%, which tells you that there's either overuse or underuse, but someone's not getting it right. And then more recently, 3 New York City hospitals, about a decade later, after more recommendations had been issued, found 2 hospitals with about 80% use and 1 hospital with only 63% use. That's about all I've been able to find on this in US data. Next slide, please. So turning to magnesium sulfate in preterm labor, here the goal is not perinatal mortality, but actually the prevention of brain damage, prevention of cerebral palsy. Next slide. And this work was very much stimulated by 2 case control studies that were done in the 1990s, showing very strong odds ratios for reduction, lowered odds ratios for CP in children, premature babies who had happened to get magnesium sulfate in labor. There were several indications in those days, control of preeclampsia. Some thought that it could be a tocolytic, although it's not really effective at that. Rare uses for control of maternal seizures, but most of these babies got it because their mothers are preeclamptic. That raises the question of you have to control for the presence of preeclampsia, which is associated with somewhat better outcomes among prematures. One cohort study that I know of, we showed an odds ratio of 0.63. It wasn't significant in our data, but as I'll show you in a moment, actually the odds ratio may have approximated the trials a bit better than some of the more significant results. Next slide, please. So this is these are the trials, the odds ratios for CP in 5 trials. 4 of the 5 showed a reduction. The most important one was the BEAM trial in 2008, published in the New England Journal of Medicine. And the pooled odds ratio from the meta-analyses is 0.68. So about a 32% reduction in risk of cerebral palsy, very well worth having in babies under 32 weeks or 34 weeks, depending on the recommendation. Next slide. So Callan Crowther from Australia wrote first authored a individual level meta-analysis, meaning that they had access to the data in the trials, and they concluded that prevents cerebral palsy and even the combined risk of fetal death and cerebral palsy. And they claimed the benefit is seen rather widely in many kinds of preterm babies. And of course, this is very inexpensive. It's not an expensive thing, and it could perhaps be a very significant intervention worldwide, not just in the US. Next slide, please. Now, the ACOG recommendation, which came out in 2016, is actually a little, frankly, a little less definitive than you might say. For example, the Australian and Canadian obstetric societies have endorsed mag sulfate a little more powerfully, but here ACOG and Society for Maternal Fetal Medicine have talked about 3 uses of magnesium in labor, one of which is fetal neuroprotection before anticipated early preterm, but they don't really give much details, and they don't endorse it as a uniquely for that purpose, but along with many other things. Next slide, please. So we have very little information on how well the magnesium sulfate intervention is implemented. I could only find one real study. It was from Canada, and actually it was a training program to try to increase magnesium use in preterm labor. And in 2011 to 2015, among 3,000 eligible women, 46% received magnesium sulfate. I'm not showing the slide, but I was shown some data from Europe from about the same vintage or perhaps a little earlier. And the figure for in Europe for eligible women was getting mag sulfate was less than 10%. So we don't know what it is in the US, but in Canada, even in hospitals who agreed to participate in a training program, it's only 46% in recent years. Next slide, please. So we decided to put in an echo-wide analysis proposal. Who is we? I list out my colleagues in this effort. Judy Ashner, who can't be on this call today, she told me. Jim Deering, who is a really very well-known implementation scientist. Alyssa Farrow has joined us recently from Albert Einstein. Kelly, as you've heard before, Shilpi Mehta-Lee, who is in maternal and fetal medicine, and Mike O'Shea, another neonatologist like Judy, have joined together. And we would like to assess the implementation of these two therapies across ECHO cohorts. We think we have a number of cohorts that will be able to provide this information. And I must emphasize that a great strength of ECHO is we're all across the country. We're very diverse. We have urban, rural populations, and all sorts of different settings in which mothers might be treated in labor. Next slide, please. So what could we do? Our thought is that we could identify cohorts in which these treatments are recorded. So our premature cohorts, Judy Ashner and Mike O'Shea, are very involved in either multiple premature cohorts or one large premature cohorts, and perhaps even some general cohorts who might have data on babies under 32 or 34 weeks. I think we'd like to look at the broader category and break it down by usage, examine overall use by subgroups, gestational age, urban, rural hospitals, academic, community hospitals. The provider type, is it maternal fetal medicine, OBGYN, general practice or family practice, midwife, and patient characteristics. Look at dosage, look at time trends, and for both interventions, compare the rate of implementation around the country under different settings. Next slide. So some difficulties we'd have to think about. Do we have enough cohorts who've collected data? We have, in our preliminary analysis of things, we certainly have several. We hope it'll be enough to really look at a range of practices. Will cohorts be willing to review medical records if these interventions are not recorded in their research databases? Perhaps these might be discoverable if you did the work, but that might be extra effort. There are some situations where mothers should not get one or the other of these interventions. Can we distinguish those from our data? Could there be, along with this, inappropriate use of these interventions? And is the time period of birth of the infants in the cohorts appropriate? We have to consider that the steroids practice dates back to the 1990s, but for magnesium, really the first meta-analysis is 2009. I don't believe there was a recommendation, at least in the US, before 2010. So this is a more recent vintage intervention to examine. Next slide. So sometimes we talk about big wins in ECHO. I have a feeling that implementation per se is something that many epidemiologists and many scientists haven't paid enough attention to. We think we've done our study and then our work is over. We've published it. What more could be needed? But Jim Deering, I like his quote, something he's written in one of his publications. The state of the science is what researchers know, and the state of the art is what practitioners actually do, and they often operate autonomously. And anybody who's been in practice knows that this is really true. And as I'll emphasize again, we have large size, we have diversity across the cohorts by many factors. And I would say that it's likely there are many effective interventions other than the two we use here as examples that vary in their implementation, of which ECHO offers a really good opportunity to understand implementation gaps. And I agree with Kelly. I encourage people on this call to contact us. Perhaps we can start an implementation work group in ECHO who are interested in the concepts of implementation science and how they might be carried forward. Next slide, please. And here is perhaps a little bit of a radical suggestion, but let me try it out on people here, see how they respond to it. Should implementation be a required part of trials? What if NIH or other funders required all trials to have an implementation plan? Should the trial find a meaningful difference affecting treatment? Some trial locations might even have a healthcare system in which implementation might be tested. Or should NIH have a funding pool alternative just to test the feasibility of implementing successful trial results? I don't believe there's any such funding pool right now at NIH. And perhaps could ECHO lead the way in opening up more effective ways of getting our science really out to the people, perhaps especially using the clinical trials network? And in general, can we build implementation into our scientific agendas for the future? And I believe that is my last slide, which if Beth goes further, there's nothing. That is the end of the slideshow, as the slide says here to me. So thank you very much for listening, everybody, for joining in. We have 118 participants. That's quite wonderful. And I hope you have questions that Kelly and I can answer or try to answer, and can engage in the discussion on the topics of the day. So thanks very much, everyone, for listening.
So Kelly and Nigel, thank you so much for the presentation. Couple housekeeping reminders. If you'd like CME credit, oh, there it is. It's also in the chat box. If you do have questions, please enter them into the chat box so that we can see them and we can call on you. We're not using the raise your hand function. We reached out to 4 discussants, which I'll be calling on shortly. Shilpi Medali, Mike O'Shea, Patrick Tarwater, and Rob Welch. But I'm actually going to start with Chris Forrest, who's my boss on the Echo Discover editorial board, because he's my boss, but also because I thought he had a good general question to start us off. So Chris, if we can unmute Chris and have him pose his question.
Thanks, Tom. Chris Forrest here from Philadelphia. Great presentation. Thanks to both of the speakers for raising this really important issue on how we take knowledge that's generated and apply it when and where it's needed. Often in practice, and particularly among trainees and junior faculty, there's confusion around the concept of implementation science and improvement science. And so I was wondering if you could touch on that. How do you characterize implementation science relative to quality improvement? And I'll just leave it at that and see what you have to say.
Will you go first, Kelly?
Sure. So I think that's a great question. There's certainly aligned goals between improvement science or quality improvement efforts and implementation science. My understanding is, in terms of the difference, really comes down to the scope. So quality improvement projects tend to be more locally focused to improve a certain situation in a clinical setting, whereas implementation science really tries to promote generalizable knowledge informed by theories that can understand the process of how we move these practices into multiple settings. So it's really, somewhat similar in terms of the aligned goals, but just differences in terms of scope of the implementation science, focusing more on the processes, whereas the quality improvement is more often focused on a specific problem in a local setting.
Yeah, I completely agree with that, Kelly. And the only thing I could say by way of addition, Chris, is that I think implementation is the big effort to get a whole concept of a new thing into a system, into the system of care, whereas quality improvement to me represents fine-tuning at the edge when you already have something pretty much out there, but you're not sure whether you're doing it quite as effectively. Maybe the term fidelity to the the guideline or to the recommendation comes up that Kelly mentioned, are you really quite doing it exactly the right way? So implementation, maybe at the end of the day, end of the task of implementation, you have to consider quality improvement, refining at the end.
That's a great answer. Thank you both for those really nice responses.
Elisa Farrow would like to add to that. So can we unmute her? And Elisa, please ask your question.
No, I just wanted to add on to, I think, the great clarifications that Kelly and Nigel offered. When I teach quality improvement implementation science, one of the ways I explain it is the quality improvement data often show, like, if we are implementing a new intervention, like, did we increase the use of a particular new evidence-based best practice? Whereas the implementation science is really the how and the why and the for whom. And so was it that different types of clinicians adopted this particular intervention differently? Did different populations, or were there different reasons why a particular intervention worked for people with a different socioeconomic status? So it's really not just if we used the intervention or not, but how we used it, if there were particular contextual factors that influenced one site using it differently than another site, or another system using it differently than another system, and why that happened, going back to the mixed methods that Kelly mentioned. And then, like I said, for the for whom, both on the sort of practitioner side, but then also on the side of patients and families.
Great, Alyssa. Thank you so much.
Thank you.
Great. I'd like to next turn to our discussants, and Mike O'Shea is up first. So, Mike, if you could add your comments.
You hear me?
Yeah.
Great. Well, first, again, thank you, Kelly and Nigel, for opening up this conversation. Yes, two comments about the antenatal steroids and the magnesium sulfate ideas. One, and you may have mentioned this. If you did, I apologize, but one of the significance, or part of the significance of doing studying those two, is that it might be one of the root causes of health disparities and perinatal outcomes. For unknown reasons, babies that come into the NICU who are African American do worse than Caucasian babies, even when you make adjustments for the relevant covariates. And so I think this would be a very nice first step in, probing one of the potential causes of racial disparity in perinatal outcomes for preterm infants. The second comment was that this is more to add to that list of cautions that Nigel included, which were great. The other one that I don't think was there was the fact that in some cases, it simply is not feasible to administer either of these because of a late presentation of the mother. We probably won't have a way to capture that, but we can, at least acknowledge that it's probably will be impossible to get to 100%. And then the last is more a question for the two of you, and wonder what you think about these ideas of if we were to form a working group, perhaps exploring the extent to which some of the AAP guidelines are implemented, such as with asthma management and ADHD vaccinations, perhaps blood pressure screening. I don't know if our data forms would allow that, but those would be intriguing to me. Just wonder what your thoughts are on those.
Oh, those are great comments. I'll just take a stab at it and then turn to Kelly. You're absolutely right. We have to think about the possibility there's not enough labor time under supervision, and that, of course, could also be a disparity factor, as you said. And we did think of looking at race to see if we could find any disparities in use. And as far as the guidelines you mentioned, yeah, absolutely, we could open up I think a large door to seeing how well things are being done. And of course, vaccination comes immediately to the fore. We have a lot of people here trying to look at vaccination. We, in fact, are going to are planning to link our cohorts in Michigan to the system called MICR, the Michigan Immunization Registry, so we can actually find out without querying the mothers which kids are up to date. And I think immunization is a very hot topic for studying implementation with complicated barriers, which we have to learn about. So thanks for that comment, Mike. Kelly, do you want to say anything?
No, I completely agree. I think there are a lot of opportunities. It sounds like those guidelines would be excellent opportunities, particularly to address some of the disparities. Obviously, if it's existing data, then it's a little bit easier. But there's also opportunities to collect additional data through other grant opportunities to use that information to inform these implementation efforts. So I think those are great ideas.
Thank you, Mike. Our next discussant is Shilpi Mehta-Lee. If we can unmute her, and Shilpi, you're up next.
Shilpi, you may be muted.
Hi. So, I listened to your talk with interest, but I actually was on and off the call a little bit because of patients. So, in any case, I appreciate, Nigel, the work you've done so far on this. And I think, to be frank, I don't have a ton to add just because I missed a portion of this. So I apologize, but I had mentioned that I may or may not be able to fully be there. And I did have a patient, so I apologize for that. I'm back now, but I missed, I think, the meat of the call.
Well, thanks, Shilpi, for taking care of patients. That's
I apologize.
very important. that's real implementation.
But I definitely am very interested in sort of how ECHO can promote, the use of betamethasone, the use of magnesium sulfate, and behind the scenes, I'm very interested in looking at that implementation work. So thank you for including me.
Nigel, this is Mike. I did have one question that maybe was it Dr. Lee or Dr. Shilpi could answer, and that is the women who are getting magnesium sulfate for preeclampsia, does that subserve the need to give additional magnesium for prevention of cerebral palsy? Is there the same dose or differences in dose?
Yeah, that's a great question. So it turns out that because it was already studied in preeclampsia, we use the exact same dose for neuroprotection for the fetus for cerebral palsy. So it's exactly the same dose. If a patient is preterm and has preeclampsia, and she would just get the exact same dose of magnesium sulfate, which equates to the appropriate cord blood levels that you need in the fetus to reduce cerebral palsy risk. And the data actually reveals that even the single first bolus, if given within 20 minutes of delivery, probably also can increase that cord blood level.
Would women in preeclampsia should be getting mag sulfate in labor, or would they be getting it before labor and not getting it in labor?
So in women with preeclampsia, they would get it whenever we thought that they were imminently going to deliver within the next 24 to 48 hours. So let's say a woman comes in and she is diagnosed with preeclampsia, and we want to manage her expectantly and try to gain more time for the fetus, then that patient would not get magnesium sulfate. There is a caveat, though. Magnesium sulfate is only used in women with preeclampsia with severe features. So when we're talking about these women on magnesium for preeclampsia, it's only women with severe features. And severe features are neurologic symptoms, lab abnormalities such as LFT elevation, or drop in your platelets that would make you a severe preeclamptic. So there are some caveats. At this point, though, if we think a patient is going to be delivered before 34 weeks, we give the magnesium, whether they're preeclamptic or not, before 32 weeks, we give the magnesium if they're preeclamptic or not, for that neuroprotection for the fetus. After 32 weeks, a woman would only get magnesium in the setting of preeclampsia with severe features. In a regular preeclamptic patient or a mild gestational hypertensive patient, they do not get magnesium sulfate routinely.
Very good. Thank you. Thank you.
Shilpi, thanks for your contribution, and my apologies to you for putting you in the spot. I misunderstood your availability.
No, I wanted to be available the whole time. I just got, it's just one of those things.
Okay, thanks. Appreciate it. Our next discussant is Patrick Tarwater. If we can unmute him, and Patrick.
Great, thank you, and again, a really excellent presentation. I appreciate it very much, and some of the really just thoughts. No great question here, but to get back to some of the elements that Kelly mentioned about the emphasis or the implementation science using both quantitative and qualitative. And I think we lose sight of the qualitative, especially in echo, where we are large and we're gathering a lot of data. And I just really was in my head thinking about the mix where we get to use echo up front to measure how much it's happening, identify subgroups that may not be using it as much. We need to look at missing. Does missing mean they didn't get it or it didn't get recorded? As we said, we're going to have to do a lot of possibly going back through again for medical record abstraction and things. But mostly that any information we learn from that, I think really opens the door to subsequent qualitative studies to go find subgroups or a type of hospital or whatever with whatever it may be, surveys or small group, and start looking for the barriers to the implementation or barriers to the documentation that we're looking for or wanting to use on the qualitative side, because we don't necessarily know. Again, is missing mean they purposely didn't use it? Because we only really catch it when it has been written down and abstracted. But it just seems like the field of implementation science, this particular problem, and using echo as this great back and forth, I think, to spawn. And I don't even necessarily mean smaller studies, but focused studies for the spirit of the implementation science. And that is, we gathered data, we learned a lot, but now it opened the door for us to go find maybe the more important information on why not, barriers to the practice, barriers to the information. Just hearing what Dr. Lee had said before about some get it, but then only if it's high risk and da-da-da-da-da. And, we've got not just clinical practice, but availability, access, and judgment to dig into. And so I do like the emphasis in the field for using echo for the data, for the qualitative, but also then from that to spawn us back into echo or elsewhere for the qualitative follow-up to move the whole field forward. So those were my thoughts. There's no question in there. It's just I really like that thinking about this kind of back and forth with both the types of investigation and how echo can be there for both of it.
I'd like to thank Patrick, because you were involved with us, and you're part of the DAC, and you're the DAC connector to our plans, and I should have listed you on the slide. I apologize for that. So we really appreciate your involvement in this.
Thank you.
Yeah, thank you also for summarizing it very eloquently. I think that's part of this discussion today is really just to try to demonstrate that, we have, as myself as an epidemiologist and some of the clinicians, I think we've focused disproportionately on the etiological questions and really not focused enough on how we can address those solutions. So just having it in mind about, what we can do and how we can not just go from bench to bookshelf, but go from, our research to inform the next phase, and whether we can use existing data with ECHO to just identify those gaps for implementation scientists. Like I mentioned in that one slide, it's really a bidirectional relationship between our work as researchers in the ECHO groups and implementation science.
Thank you so much, Patrick. Our last discussant is Rob Welch. If we can unmute him. And Rob, please.
Okay, can you hear me?
Yeah.
Okay, great. Really more, first of all, I really appreciate the conversation and the presentation. I think it's very pertinent. And I wanted to, though, point out there's kind of a parallel process that's taking place, and that is through the Joint Commission on Accreditation of Hospitals. You may recall they have perinatal guidelines. Perinatal guideline number 1, or PCO1, is the 39-week rule, and PCO3 is the use of steroids between 24 and 34 weeks. So JACO data, I believe, on many hospitals, or at least they're supposed to be reporting to JACO. Now, I don't think you can go to individual hospitals and get the data, because I think their quality departments will not release it. I would doubt that they would release it. JACO may or may not release it according to hospitals, I'm not sure. But it is an interesting thing that we're really, like I said, there's this parallel process. And that process is working, I think, in some hospitals to improve implementation. Now, they're not looking at mag sulfate. And I'm not aware of anybody looking at mag sulfate at this time in terms of neuroprophylaxis. But the steroid issue is being addressed, I think, from a regulatory standpoint.
It's good to know, Rob. I did not know this. We're going to take advantage of that information too and figure out how we can use it. Thank you very much.
Okay, great. Nice talking to you. Thank you.
See you, Rob.
Next, we had a comment in the chat box from Asia Ferrara. If we can unmute her. And Asia, you are up.
Hi, can you hear me?
Yeah, hi, Asia.
Yeah, wonderful presentation. I joined in the meeting a little bit late, so I didn't see all the background. But speaking of implementation science, besides evaluated whether in the clinical setting some evidence-based treatment are used or not, and whether they're used consistently across demographic of the patients and geographic area. It's also important to evaluate whether the intervention or the treatment works as well it works in the clinical trial when implemented in the clinical setting. Maybe in this case for preterm, we can assume the corticosteroid can work, but what if they're not given at the right time or not given at the right dose? So an evaluation of the effectiveness also is very important. It's not just whether implemented or not. And another point that, we had a clinician here at Kaiser who were interested in evaluating the corticosteroid treatment for preterm, and we did a pilot study. It's very hard to figure out whether in the medical record whether a patient was given the corticosteroid or not. So just as somebody else also said, that talk about the difficulty to extract this information from the medical record. Often it's not reported, even they know, the clinician know that patient was given the corticosteroid.
Yeah, those are good points, Essia. We certainly would definitely look not just at yes or no, but also the manner, the dosage, and the timing, etc. And of course, we did wonder about how much we can get out of the medical records. I think that the preemie cohorts, and maybe Mike could weigh in on this, Mike O'Shea, probably will generally record this in their scientific database because it's thought to be important. It's often asked, I think neonatologists routinely ask the obstetricians, were steroids given in labor to this particular mom? Mike, do you think it will be hard to obtain these data?
I think that in Barry Lester's cohort study and in the Elgin study, and very likely in Judy's study, it will, as you say, already be in the extant database for the inception cohorts. So it'll just be a matter of gathering that.
Thanks a lot.
Okay, I think we have time for another question. Bill Pfeiffer put in a comment. So Bill, if you'd like to speak up now.
Sure, thanks. And thank you, folks. I really, it's something I know so little about, but I'm glad I feel like I'm educated and maybe know enough to be dangerous. And I was going back to Nigel's original point saying that, or one of the points saying that this really could be an echo leading the way exemplar. And I'm just wondering, I know here where I am that I'm involved with cohorts that aren't part of ECHO, but that data could be readily available. And I don't think it would take too much encouragement for people to join in the sandbox if, again, someone else was already motivating and organizing the effort. So I just wanted to put that out there, as there may be other people in that same position where they're familiar with part of other efforts where this data may already be being collected for other reasons.
Sure, Bill, that'd be a great suggestion if we can be put in touch. I think the network of neonatologists we're beginning here will probably be able to reach out, just as you could easily, to the Columbia neonatologists, and we'd love to have them involved. And it would be nice to have ECHO be a kind of lead organization thinking about implementation, not just about obtaining data on participants, but actually thinking about how we can use these data to implement, to improve practice, and learning what the barriers might be. That could be part of a real research agenda for us. And I want to underline something I said before. If you want to join in on this, and either in the conceptual part, or the specific topic, just email me on Paneth at MSU, and I'm sure Kelly will share her email address, and let us know about your interest, and we'll try to work things together, as well as any interest in creating a special interest group within within ECHO, dealing with implementation in general.
I'd like to thank everyone, especially Bill, and that was a perfect segue, Bill. Please join us next month, where he'll be talking about sleep. Two quick housekeeping things. This presentation, the slides and all the information will be recorded and available online. If there's anything folks want to listen again or get more information on. And please do complete the evaluation and follow-up survey. We at the editorial board and at the Corning Center really look at these closely and highly value the feedback. So thank you everyone for joining us, and look to talk with everyone next month.